Two, one. Please start.
Yeah. Good evening, everyone. Good evening, our eminent speaker, Dr. Somnath Chakraborty sir and Dr. Subhranshu Sengupta sir. So, I will like to give a brief introduction about both of our speaker. Dr. Somnath sir is from Retina Institute of Bengal, Siliguri. He is the senior most retina surgeon in Siliguri and in West Bengal also. And he is a vitreoretinal surgeon from Retina Institute of Bengal. And sir is previously associated with Arvind also. So today, sir is going to talk about evaluating the needs for change, evidence, and insights on anti-VGF therapy. And our second speaker is Dr. Subhranshu Sengupta. He is the senior most retina specialist from Center for Sight, Kolkata. And sir is the topic sir is going to talk is about the evolving role of aflibercept in PCV, APPRS insights, and compensations with anti-VGF agents. So I would like to welcome both of our speaker, Somnath Chakraborty sir and Dr. Subhranshu Sengupta sir. So the first talk is from Dr. Somnath Chakraborty sir. So I would like to request Somnath sir to kindly start your talk. Thank you, sir.
Thank you, Saurabh. Thank you for that kind introduction. Uh, yes, I hope my slides are visible.
Yes, sir, it's visible and your video and audio is also visible. Thank you.
Thank you. So good evening, everyone, and thank you, Bayer, for this opportunity to share this talk with the delegates today. So I'll be talking on evaluating the need for change, evidence, and insights on anti-VEGF therapies. So these are my disclaimers. So if we look at the current management of wet AMD, there are multiple choices that we have. Now in this particular slide, because it's from Bayer, it's probably an international slide, so that's why they have not mentioned biosimilars. But we know in India, we have also biosimilars besides bevacizumab, ranibizumab, aflibercept, brolucizumab, and faricimab. However, even though we have so many choices now, it is a fact that there is still no cure or timely treatment. So basically, there is nothing that can assure our patients that if you take this for a certain fixed number of times and you will become completely cured of wet AMD. But we have to unfortunately keep repeating the treatment with the hope that this will inhibit new blood vessels, which actually cause visual loss by leaking. And therefore, because the treatment is repetitive and prolonged and practically almost, you can say, continuous, therefore, in real world, it is very difficult to actually maintain patients on the protocols that has been suggested based on RCT guidelines. So, okay, sorry, just 1 minute. I think the slides, yeah. So basically, that's the main thing. That in real world, one, we cannot follow protocols. Secondly, there are inter-individual differences, and also the various anti-VEGFs themselves. We find that there are difference in the way they work, and there is still therefore no consensus on what should we call a proper optimal response, or rather lack of optimal response, and how and therefore no real clarity on what is the ideal drug that we have amongst all the choices available right now. So when we talk about response of to an anti-VEGF, there is a primary response and then there is a secondary response. Primary response is usually the response 1 month post the last loading dose, and we know the loading dose usually again varies from agents to agent. The secondary response is any time after the fourth visit, and there is another thing that has been said here, that basically there is what we call a ceiling effect, because if patient starts with a certain amount of good visual acuity, there is only so much vision that the patient can gain, beyond which because nobody can really become better than 6.6, though in wet AMD that is also very rare, I would say, at least in my practice. And we know that there are certain diagnostic tests which may help us differentiate subtypes of CNVMs, like ICG to diagnose PCV or RAP, And these are also these cases or these subtypes respond differently to different anti-VEGFs. However, in the real world, it's not that many institutes do not have access to ICG, and therefore real world data in real world data, the response, when we judge response, often we are combining wet AMD patients with PCB or RAP lesions, and this may alter the final outcome. So here is a definition of how we can define response. So good response is when you have absence of fluid with a central retinal thickness reduction of more than 75% and improvement of vision of more than 5 letters, that is one line. Of course, we have to also see that there might be a ceiling effect, which we have already discussed. Partial is when the reduction is between 25 to 75%, and there may be some persistent fluid with change of visual acuity between 1 to 5 letters, that is less than one line. Poor is when there is less than 25 reduction in central retinal thickness and persistent of fluid, and there is hardly any change in visual acuity, 0 to 4 letters. Non-response is if there is absolutely no change or there is a decline in vision. So when we switch from one anti-VEGF to another anti-VEGF, because this is something very often asked, that when should we switch and what should we switch to? So before we switch, we have to understand why are we even thinking of switching, and does switching really help? What does the data show? So real world studies with faricimab, which is the latest anti-VEGF that we have in wet AMD, shows, and most of these patients were patients who were switched from aflibercept, that actually in the real world, there has been very limited vision gains post-switch. And this is after a significant number of faricimab injections, 3 in these 2 studies from Mukai and Truckee, and 4 faricimab injections from this Moorfield study and Far Retina study. So that means it's not that we just give one faricimab injection and assess those patients. Even after multiple injections, if you see here, that even post switching from aflibercept, the visual gain was hardly 2 letters. And in few studies, like in the Moorfield study, there was actually no change. Similar, the same with Far Retina study. In the treatment naive patients, where there cannot be that cannot be a question of switching, because in a treatment naive patient, we mean that patient has been initiated therapy on that. There, the visual gains naturally, as expected, are bit different. But in a patient who was already under treatment and we switched to faricimab, in spite of multiple injections, the gain in terms of visual acuity is not significant in the real world. As a matter of fact, another interesting finding from this study by Kato Hakka et al. Is that patients who were switched to faricimab from aflibercept, majority of them actually decided to return to aflibercept. 60% discontinued with faricimab treatment. And in majority of them, the discontinuation was because there was insufficient efficacy of faricimab. And most of these patients decided to switch back to aflibercept. Patients are often switched between drugs, not because we expect more drying or more visual gain, but also because we hope that after switching agents, there will be reduction in the treatment load. So that's why when Kishi et al. Tried to find out if switching a patient from aflibercept to faricimab could reduce treatment burden, they found that even after switching to switching to faricimab, which technically or theoretically should have increased the treatment interval, but most patients actually remained on less than 8 weekly, that is 2 monthly injections. So after 3 loading doses, significant visual outcomes were observed with aflibercept compared to faricimab. This is another thing. So if you just take a treatment naive patient and give 3 injections of aflibercept versus 3 injections of faricimab, the visual gains were seen to be better with, you can see this, significantly more visual gains. The blue are the aflibercept patients and the gray is the faricimab patients. So significantly more visual gain with the 3 initial injections. And in real world, these things matter because patients are paying out of their pocket, at least in our scenario. And therefore, if they do not perceive any gain, they often drop out from treatment, or simply instead of agreeing to switch from one agent to another, they switch doctors. So 6 months of real world study, this was with wet AMD. The 6 months of real world study with faricimab in DME also has shown limited visual gain. So 72% of previously treated eyes that because they also wanted to see if switching from aflibercept was making any difference. So of those eyes which were already previously treated, 72% were actually on aflibercept. And if you can see here that not much, even with the after three faricimab injections, only 0.8 liters gain. So and then again after fourth injection, it remained more or less same. So no significant gain in extra gain with the new anti-VEGF. And also the second aspect that okay, vision gain may not be there because of ceiling effect. What about increase in the treatment interval? So even there we found that. Despite multiple faricimab injections, majority of patients had to be maintained on a less than 2 monthly or 8 weekly interval. So switching to faricimab neither gave extra visual gains nor reduced the treatment burden. So this was an interesting study which actually evaluated the effect of switching anti-VEGF agents in AMD and DME. This study actually had a very interesting finding. So if you see here, but the basic question that the study has was, does really switching help? And their conclusion was that it actually switching in many patients gave the same amount of improvement that would have happened had we instead of switching just persisted with that particular anti-VEGF agent. And therefore they said that any study which claims that there was a gain with switching first should have a control arm where the same original agent was continued. If it doesn't have, then it is possible that the conclusions are wrong, because when the authors did the study, they found that it is not uncommon for the patients to actually gain once we continued with the same original agent and did not switch. So the other question is that why these newer anti-VEGFs are being sought. Because, for example, we know in faricimab, the biggest positive or the plus point that we all have been told is that it is not just a simple anti-VEGF blocker, it does more. So does blocking other pathways beyond anti-VEGF really, are they really giving any benefits in the real world? So if you see, these are few of the options that we have now of how we can go beyond the so-called traditional anti-VEGF. One is that there are some studies where aflibercept was combined with a drug called nesavizumab, and then of course you have faricimab, which not only blocks VEGF but also ANG2. Then you have brolucizumab, which is a unique antibody fragment, therefore a small molecule, and acts on anti-VEGF and has its own unique features as an anti-VEGF. And the other is, of course, that if you have a depot inside the eye which continuously keeps blocking blocking the VEGF, that may help in reducing the treatment burden. So the first thing we will see is what happened if we combined aflibercept with this new drug nesvacumab. And there were two studies, the Ruby study, which was for diabetic macular edema, and the Onyx study, which was for wet AMD. And they found that there was actually no additional benefit. Even if we added nesvacumab, which was a potent ANG2 inhibitor, it did not give any additional benefit vis-a-vis aflibercept alone. And what about faricimab? So again, if we look where the two studies where aflibercept was compared, or rather faricimab was compared to aflibercept, the TENAYA and the Lucerne study, the conclusion was that faricimab was non-inferior. In other words, we can say that aflibercept and faricimab, even though faricimab was having an ANG2 blocking effect, but they were ending up providing the same visual outcomes. So when there was another interesting study, this Avenue study, where actually they just gave a single injection of ranibizumab and faricimab, and then they wanted to see whether how much was the plasma ANG2 inhibition. And the interesting finding was that actually ranibizumab was also blocking ANG2 as much as faricimab, which is supposedly which has a specific additional ANG2 blocking effect. In other words, that if you can see here, based on this study, the authors concluded that it seems that there is no additional anti-VEGF, no additional benefit of a drug like faricimab over ranibizumab from the ANG2 blocking phenomena. So, based on all these studies, this presentation suggests that role of ANG2 has not yet been established, and it may have been more of a hype than or a hope, that it is not really, neither it is giving additional benefits visually in the real world, nor is it reducing the treatment burden as we expected. And that's because preclinical data says that the key driver of ANG2 production is anti-VEGF. So if you can block anti-VEGF properly, it eventually affects the ANG2 generation also. And the best anti-VEGF blocker that we have, so in other words, VEGF is the main driver of the pathology. So we need a drug which actually best blocks VEGF. And we know that the best blocker for VEGF right now is still aflibercept, which has a dual receptor blockage. So, so with that, what the last slide would be is that the new thing that is we now have, we think that anti-VEGF and additional pathway blocking is not really helping. Anti-VEGF blocking is maximum with aflibercept. So if we have to think of anything beyond this, probably that would be aflibercept high dose or 8 milligram. Once that is available to us in the real world, we will know whether that is giving any additional visual gains or really helpful in reducing treatment burden, both of which are still an unmet need in managing retina patients. Thank you so much.
Thank you, sir, for such a insightful presentation on aflibercept and the new drugs faricimab. And now our second talk, I would like to request Subhranshu sir for his talk. The name of the talk is the evolving role of aflibercept in PCV, FEVRS insights and comparisons with anti-VEGF agents. So, sir, kindly start your presentation. Thank you.
Yes, am I audible?
Yes, sir, audible, and
Okay.
slides are also visible, sir.
Okay, great. So basically, I'll be talking about the evolving role of aflibercept in PCV, APVRS insights and comparisons with the anti-VEGF agents. I'd like to thank Mr. Shourabh and Team Bayer for having me here, and Dr. Chakraborty and all other consultants for their valuable time. So these are my disclaimers. So if we are to look at the initial treatment, if we are to look at the APVRS guidelines update 2025, when we are diagnosing PCV, we look at the OCT markers like sub-RP ring lesions, then maybe NFAS, OCT complex and RP elevation, and sharp peak PED. And of course, for confirmation of PCV diagnosis, we go in for multimodal imaging like ICGA. So what is the initial treatment? Obviously, anti-VEGF monotherapy, and we do have the option of anti-VEGF with PDT. And the response is monitored with the help of OCT and or ICGA. So either we can have complete stabilization and regression of SRF, wherein we will actually extend intervals with the treat and extend regime, or there might be persistent recurrence of disease activity. There might be persistent recurrence of disease activity, in which case we'll shorten intervals with treat and extend regime, or we will combine treatment with anti-VEGF and PDT or switch to another anti-VEGF agent. So what are the exact guidelines? Monotherapy with anti-VEGF treatment is effective in many cases of PCV and can be used initially as monotherapy. Now here the consensus score is very high, 95%, and that is actually quite high, with 66% of the participants agreeing strongly to this particular statement. So if we are to look at the molecules that are there very briefly, we have the main anti-VEGFs being aflibercept, brolucizumab, ranibizumab, and faricimab. First and foremost, if we are to compare the binding affinity, it is the highest with aflibercept. The KD value is actually inversely proportional to the binding affinity, and the estimated half-life for aflibercept is about 9 to 11 days, and whereas it is single for brolucizumab and ranibizumab, and faricimab has dual targets. Potency-wise also, definitely aflibercept scores over the others. So now if we are to look at the various, pivotal studies that are there, in 2016, pivotal aflibercept trials demonstrated that PCV can be treated similarly to neovascular AMD. So if we look at the VIEW 2 study, here the mean change in BCVA at week 96. Here it was found that patients with PCV and patients with neovascular AMD achieved similar vision gains with aflibercept monotherapy. This is the PCV arm with having plus 11 ETDRS letters at week 96. If we are to look at the PLANET study, there also it was concluded that PDT can be reserved as rescue therapy for suitable patients. However, if we look at the visual acuity gains, in the monotherapy arm, it was 10.7 letters gained, whereas in the aflibercept plus rescue PDT, 9.1 letters. However, the difference was not statistically significant. So if you look at the PLANET study, PLANET was a prospective sham controlled study. Here, initially, all patients were exposed to 3 monthly doses of aflibercept 2 milligram, and then there was 1:1 randomization. In the first group, at week 12, from week 12, aflibercept 8 weekly monotherapy was started, or rescue treatment defined as aflibercept 4 weekly with sham PDT. Whereas in the second arm, it was aflibercept 8 weekly or rescue treatment, which was defined as aflibercept 4 weekly with active PDT. The primary endpoint was the change in BCVA from baseline at 52 weeks and the safety outcomes. The study was continued further with aflibercept treat and extend, or aflibercept with sham PDT in one group, and in the other group, it was either aflibercept treat or extend or aflibercept combined with active PDT, and the endpoint was week 96. So if we have to look at the graph, we will find that in both, that is the aflibercept 2 milligram monotherapy as well as the 2 milligram plus rescue PDT, in both the groups, the increase in visual acuity, the ETDRS letters, that is comparable in both the groups. Secondly, patients with extended intervals in year 2 maintained vision gains with a reduced treatment burden. As Dr. Chakraborty just now pointed out, this is a very important thing. That is, reducing the treatment burden is probably, foremost our minds when we are treating these patients who keep coming back to us over the years. In the Altair study, vision gains are maintained with aflibercept 2 milligram or without PCV. Similar proportion of patients with or without PCV were extended to intervals of more than 12 weekly dosing by week 96 with aflibercept 2 milligram treat and extend regimes. Subsequently, Maruko et al. Reported similar outcomes with aflibercept 2 milligram treat and extend through 2 years, regardless of neovascular AMD subtype. The real-world patients with PCV can achieve vision gains that are comparable to these randomized controlled trials, as has been enumerated in multiple studies, many of them from Japan, and so on and so forth. Complete polyp regression have been observed across real-world case series with aflibercept in PCV in various studies. Now, if we just look at one particular study head-on-head with the PLANET study, so the SALVIN study is a single-arm, open-label, treat and extend style study. So in about the PLANET study, we have more or less gone through just a short while ago. In the SALVIN study, it is basically a multicentric, open-label, single-arm study wherein faricimab was given. There was no comparator. There was no masking also, whereas the PLANET study was double masked. There was no masking in the SALVIN study. In PLANET study, initially there were 3 monthly loading doses, In the Salvin study, there were 4 monthly loading doses. And the primary endpoint was non-inferiority of aflibercept monotherapy versus aflibercept with rescue PDT for BCVA change from baseline to week 52, whereas in the Salvin study, it was mean change in BCVA from baseline averaged over weeks 40 to 48. So cross-trial comparisons are of course limited by differences in trial design and definitions, and of course have to be interpreted according to their own merits. So if we had to look at the aflibercept versus faricimab in PCA patients after 3 loading doses, it was significant visual outcomes were actually observed with aflibercept. If we had to look at this particular graph, the BCVA significantly improved only in aflibercept group at month 3, whereas after the first treatment, but no significant improvement was observed in the faricimab group. This is actually logMAR BCVA, so definitely there is no significance here. Now, all type of fluid was numerically greater with aflibercept in the proportion of eyes with complete lesions in the aflibercept group. So conclusions of the Hara et al. Study, head-to-head comparison of real-world study in treatment-naive AMD patients. All patients were Japanese population. Both aflibercept and faricimab treatments are definitely effective in reducing exudation retinal thickness. However, aflibercept was more likely to eliminate exudative changes and hence improve the visual acuity after loading doses. Now, I'll just run through one very interesting case of mine. I mean, this particular patient is actually the maternal uncle of one of my medical college batchmates. So this person is now 68 years old, smoker, hypertensive. So I have probably been following up him up for now 8 to 9 years. Initially, he came with classic pictures of PCV. We had done ICG and all that. I'm just showing the current picture actually. Let's this is the right eye of that particular patient. This was the picture I think in about 2023. So with the time, a lot of scarification had also taken place. This was more or less the picture. So he has received numerous injections of ranibizumab around 2022, 23, I think. Because of his claim issues and all that, he finally could switch to aflibercept. So initially, after the first injection was given, the reduction was not very significant. But after the second injection, I think after the second loading dose, we got good improvement, which maintained over the third loading dose. Then we can see the signal strength going down here because of cataract, after which he underwent cataract surgery and all. But what is very important now is that over the last couple of years, his right eye has been maintaining at this level more or less with around 3 to 4 monthly treat and extend regime of aflibercept. The left eye of the same patient, this is what was the situation initially with injection over time, aflibercept only. It reduced. Now what we have, though there is definitely foveal thinning, his vision is actually about 612 or 612 part in both the eyes. But you can see that this subretinal fluid is more or less gone. In this eye also, he receives an aflibercept injection about every 4 to 6 months or so. So to conclude, aflibercept 2 milligrams efficacy and safety profile has been established across randomized controlled trials and is supported by over a decade of real-world monitoring. What is important is that very important are the low rates of adverse events observed with aflibercept, and hence This is actually a very, very important molecule in our armament, including PCV. So thank you so much.
Thank you very much, sir, for such an insightful presentation and followed by a case presentation also. And I think we are at the end of this meeting, and now the forum is open for the discussion. So I would like to request our audience as well as the speaker, if there is any question from our speaker, so we will discuss it now. So we will wait for 2 to 3 minutes for the discussion. Yeah.
So if I may ask Dr. Somnath itself, just an exchange of views, like, the treat and extend regime that we all follow, on an average, when you're dealing with AMD, do you routinely get, maybe you can space out the treatment over 3 or 4 months when you're into second or third year with aflibercept? In most cases, I know there would be exceptions, of course.
Yes, good evening, Shubhranshu. That's a wonderful question. I don't do treat and extend because sometimes simply our patients can't afford that. So I'll be very honest with you. But our experience with PCB patients have been far better than wet AMD, as you rightly said. The PCB variant, we can extend longer drug-free intervals. But in wet AMD, I think what happens invariably in the real world is the patients stop coming actually once they experience stability of vision. But that cannot be, but we know now that often patient is having a good vision, the OCT may be dry, but Octa may be already showing a quiescent network. And we don't know what we should be doing. But these patients sometimes don't come, and then when they come, there's already activity. So, all those challenges are there. But I agree with you. Wet AMD has a relentless sort of a picture. We need to be very cautious and aggressive. And ideal would be treat and extend, undoubtedly. If patient can afford, best every 3 months at least one injection. But PCB maybe we are very fortunate that we probably have a large group of patients who are actually PCB, and they can go longer on longer drug free intervals. That has been my observation. I would love to hear from about your personal experience, Dr. Shubhranshu.
Very similar in my case, sir. More or less, the case which I showed actually, in the right eye, the patient had undergone PCV, undergone PDT. It was still available at that time. It was, being phased away at that point of time. I, along with Sinha sir, Dr. Saurabh Sinha sir, we had done the PDT at when I was in my previous institute in the right eye. But somehow, even with scar and all, magically this guy is maintaining 612, 612 part in both the eyes. And now he comes back saying that, look, I need an OCT and an injection. He knows now when to come back. So
Nice.
that easy for me.
Saurabh, any more questions?
Sir, it's a nice discussion today. I don't think there is a question left. And we are grateful that we are having such an experienced speaker like Somnath sir and Shubhranshu sir in today's forum. And we are always looking for this kind of opportunity in near future also. So thank you very much for coming to the meeting, sir, by our organized meeting. And good night. Good night to everyone, sir.
Thank you, and good night.
Thank you, everyone. Thank you, sir.
Good night. Thank you. So, tech team, you can close the meeting.